Hi everyone, and a warm welcome to you all today. Thank you for joining our webinar looking at primary care, cancer and inequalities. It's really great to see so many of you in our audience. Thank you to Toby for taking the time to connect with us and share your knowledge on what I think is going to be a really interesting topic. By way of a quick intro, our speaker today is Toby Watts. Toby is Senior Economist at the Health Foundation, an independent charitable organisation working to build a healthier UK. Part of the Health Foundation is the REAL Centre, Research and Economic Analysis for the Long Term, which provides independent analysis and research to support better long-term decision-making in health and social care. Toby's work focuses on diagnosed health inequalities using primary care data. You can see lots more about Toby, his work and his publications on the Health Foundation website. Today, we're talking about just one of Toby's areas of expertise, which is a focus on cancer, inequality due to social mobility and deprivation, and the role of primary care. He will also be exploring how the COVID-19 pandemic and lockdowns has impacted on all of this. From what I've heard, Toby could talk about this topic for days, but he's prepared a short talk to take us through some of the key insights over the next 40 minutes. Just a few housekeeping points. Thank you to those of you who have already submitted your questions for Toby. You can submit additional questions throughout the session via the Q&A function on your screen, and we'll try to answer as many of these as possible at the end. Toby's also said that he's happy to answer any specific questions that come up during his talk, so please flag if you'd like him to address anything specific there and then. Finally, this will be recorded and the recording of the virtual event will be circulated afterwards. So without further ado, I will hand over to Toby.
Yeah, thanks very much, Elizabeth. So yeah, I'll add to that. Thanks very much for those kind words. I will add that a disclaimer that I'm an economist. I have no medical training and very little experience using the healthcare system, especially for cancer. And the work that I've been doing, and I'm going to talk you through, started actually with the pandemic. So at the Health Foundation, we are lucky enough to have access to some excellent data that's all pseudonymized, and the reason that we're allowed access to this is because of kind of investment in secure data environments and infrastructure. We got access to primary care data just before the pandemic started. And we were in a position that many people making decisions weren't in, and getting access to kind of up to the minute, or not quite up to the minute, but data that was kind of several weeks old. So when the lockdowns started to happen, people stopped showing up to primary care, and we were tasked with doing lots of analysis as quickly as possible to determine who wasn't showing up to primary care, hopefully kind of why not, and how was that impacting, how was the kind of non-pharmaceutical interventions associated with COVID, the lockdowns, how were they impacting the way people use the system. So it works if I click, yeah. So I'm going to go through it almost in order which I was kind of doing the learning in the first place. So we'll talk a little bit about the primary care data. This really generated the interest in cancer because cancer was very badly affected by the lockdowns of the pandemic. So there were kind of, I think, I don't know about how the estimate has changed in the last, say, year or so, but kind of 40 or 50,000 missing cancer cases resulted from the pandemic and the lockdowns. I'm going to talk about routes to diagnosis. So primary care plays a huge role in cancer diagnostic, in a cancer diagnostic process. I'll talk a little bit about the setup pre-pandemic. So primary care investment was relatively limited, especially during the austerity period. I'll talk about the details of inequalities in cancer. It's multidimensional, both in terms of the likelihood that someone's diagnosed with cancer in deprived areas versus wealthier areas, the age at which that happens, but also the types of cancer. So they're more likely to be killers, and outcomes tend to be worse for people living in deprived areas as well. I'll talk about how those things were impacted during COVID and the socioeconomic inequalities therein. And then I'll talk a little bit about speculation and further work and focusing on the what I think is the kind of missing link between primary care policy and cancer policy, especially directed at inequality, at minimising or reducing inequality. The data bit, okay, it's relatively uninteresting, but it's worth going through. So GPs are all independent businesses. In health economics research, lots of people have access to secondary care data, hospital episode statistics, because the payment system for those services, the way that hospitals are reimbursed, depends on how well everything is recorded. In primary care, that's not the case. And there are two computer systems on which GPs make their patient records. One's called EMIS, one's called System 1. The CPRD, Clinical Practice Research Data Link, allows access to one of those computer systems and cleans the data for us. And what we have is complete patient histories. So for patients who are diagnosed with type 1 diabetes at a young age, if they're in our data now at kind of the age of 60, we should know that they have type 1 diabetes and know when it was diagnosed. And this gives us a much better understanding of long-term illness, inequalities in long-term illness, which is kind of missing a little bit from policy research and policy discourse, especially over the last kind of 20 years, or I guess even longer. As I mentioned, throughout the pandemic, we were loading in data that was kind of 8 weeks old and feeding into NHS England, DHSE and the delivery unit. And yeah, access to these data is a challenge, and it's expensive. It requires a lot of investment in safe data control and in infrastructure. So we're very lucky. So focusing on routes to cancer diagnosis, and if this looks like a complicated diagram, that's because it is. So the patient experience of cancer, you can have no noticeable symptoms but still have cancer growing in your body. You can start to pick up that noticeable change, and then symptoms associated with cancer can become very severe. So extreme pain, unexplained weight loss. In the case of, well, it depends on the location of the tumour, but in each of those settings, kind of the relationship between the patient and the GP is absolutely vital, because that's, other than through screening, the route to diagnosis travels through GP appointment. And actually, so 66% of cancers that are ultimately diagnosed come through primary care. 13% of these are from routine referrals. So there's a set of guidance for GPs called NG12, which basically gives a list of potential symptoms that could be considered red flags. And if patients meet these kind of criteria, they qualify for an urgent cancer referral, which means that they are supposed to be seen within 2 weeks. Sometimes cancers are referred just as routine referrals and then upgraded after an initial outpatient appointment. Screening is 7% of cancer diagnoses, but there are only there are 3 national screening programs, and that's breast, cervical, and lower intestine, small intestine, bowel cancer screening programs. Sadly, many cancers, 17%, come through emergency admission, and that's basically where you get to the point where the for whatever reason, either access or well, for whatever reason, you present with your symptoms in emergency setting, and then you get upgraded and then diagnosed with cancer at that point. So primary care, to reiterate, is absolutely vital for early diagnosis of cancer, which is one of the NHS's kind of major aims. I'll talk quickly through the narrative of what I've talked about. I've actually kind of done this to some extent, but essentially, primary care consultation rates are much higher in deprived areas. In my opinion, and in that of many people, primary care resourcing doesn't use sufficient information in their resource allocation. So we have shorter consultations per head of sick patient in primary care, in deprived areas, many more consultations per head. We have higher staff turnover in primary care and deprived areas, and a lower relative number of GPs to nurses. Primary care has been underinvested relative to need, and I'll present some evidence on that. Cancer inequality is multidimensional, as I've said, and the higher levels of multimorbidity that exist in more deprived areas creates complexity, and people living in deprived areas often have lower levels of health literacy, what I'm going to refer to as kind of blunt elbows. You basically, so a key aspect of early cancer diagnosis is that kind of advocacy that gets you through that initial consultation with a GP, then onto referrals. It relies on that relationship working really well. During the COVID-19 pandemic, we had greater reductions in urgent referrals and first cancer treatments in more deprived areas. I'll talk about this, but despite actually a smaller reduction in access to primary care. So in deprived areas, there was a kind of primary care access, with the number of consultations was more protected from the pandemic and the lockdowns, but there was a bigger reduction in urgent cancer referrals and first treatments for new cancer. Policies to improve cancer outcomes rely heavily on primary care, and these policies, the cancer policies and the primary care policies, are not joined up in any kind of sensible way. Green shoots made recently, so NHS England have kind of reported on this, that community diagnostic services, so lung cancer bands, have found a lot more early stage cancers, especially in deprived areas, which is a great thing. So people are thinking kind of outside the box policy wise to try and improve the early stages of cancer diagnosis. But the way that that's kind of improving is by circumnavigating primary care, which I'm not necessarily sure is the right approach, or not a complete approach anyway. So looking back over kind of between 2008 and just before the pandemic, the average level of illness in the population increased pretty steadily. The Cambridge Multimorbidity Score is basically a weighted ranking of illness that goes all the way from hypertension, which is high blood pressure, a really low ranking, to dementia, which is the highest at many times the score. And it basically, for each condition, a higher score is given if people use primary care more often, if people are more likely to have an unplanned admission, and if mortality risk is higher as a result of having it. And essentially, the average Cambridge Multimorbidity Score can just tell you a little bit about the level of health and especially primary care need in the population, and how that changes from year to year. Compared to other areas of spend, the amount of money going into primary care in real terms has basically not grown. Particularly so in 2019, 20 and 2021, the percentage of spend of the HSC total budget was lower than it was in 2008, 2009. So this chart pulls together this chart and this chart basically. So indexing them so that we can get them on the same axis, with 100 being the level that was in 2008, 2009. This is the increase in the amount of illness in the population, focusing on the primary care aspect of that Cambridge Multimorbidity Score. This is the estimated number consultation count, which grew at a slower rate. So for the same amount of illness, fewer consultations are happening. And there's a big gap here. Although spending just before the pandemic kind of got up to that level, the big amount of negative space in here represents underinvestment in primary care, compared to the levels of need. Inequalities in cancer, so the three dimensions. So based on, this is research done by Cancer Research UK, comparing deprivation quintiles. So based on the local area index of multiple deprivation, which is a measure based on education income and it includes health as well, of a patient's local area, how likely are you to be diagnosed with cancer? And across all cancers, people in the most deprived areas are more likely than in the least deprived to be diagnosed with any cancer. So cancer incidence is more common in deprived areas. I'm quite happy with this chart, but there's again a lot on it. So each individual blob is males and females. The amount of new incidences of cancer is the size of each blob. On the y-axis, we have the percentage increase in incidence from least deprived to most deprived. So the higher you up in the chart, the more common, or the relatively more common, the cancer is diagnosed in deprived areas compared to wealthier areas. Lung cancer is because of differences in smoking rates predominantly, but also air quality and other things. Lung cancer is by a long way the most unequal in terms of its incidence. And on the x-axis is the survival rate. So 100% is everyone survives after the diagnosis of 3 years after, so 3-year survival rate, I think. Yeah. And what we see is this kind of negative correlation. So the cancers that are more likely to be diagnosed in deprived areas are the ones with the lowest survival rates. Lung cancer, stomach, esophagus, liver are all much more likely to be diagnosed, and with lung cancer, you know, we're talking over twice as likely. 100% more is twice as likely, so almost 3 times as likely. And then if you look over here, you have some cancers that are actually kind of pro-rich, so more likely to be diagnosed in wealthier areas. That's not necessarily because they're more likely to exist, they're just more likely to be diagnosed. So skin cancer, testicular cancer, prostate cancer, breast cancer, these are things where, so breast cancer, there's a screening program, and we know that people from wealthier areas are more likely to engage in screening programs. The prostate cancer is an interesting one, where there's no official screening program, but you can ask for a fit test with your GP, which is almost acts like a screening program, but you have to ask for it and you have to know to ask for it. Those kinds of cancers are more likely to be diagnosed in the less deprived areas. In addition to this, so cancer is more likely to be diagnosed in deprived areas. The cancer that you are diagnosed with is more likely to be one with a very high fatality rate. And on top of that, conditional on the cancer that you're diagnosed with, survival rates are lower in more deprived areas. That's because cancers are more likely to be diagnosed at a later stage in deprived areas. So that's all kind of pre-pandemic. I'll talk a little bit about how primary care was affected and the diagnostic process more generally was affected during the pandemic. So this is observed versus expected consultations each week, taking out flu vaccinations, which would give us a big bump around winter time, because lots of people go to the GP to get their flu vaccinations, and that kind of comes into our data as a consultation, but actually it's very often just in, jab, and out. So this was the first lockdown, March 2020, a big drop and then a slow recovery throughout the year, and then again another kind of drop away from as we went into January 2021. For that, I guess it would be called the 3rd lockdown if you include the November circuit breaker, which so as I said, primary care data has consultation rates, it has referral data, and we can separate the number of urgent cancer referrals from the from routine referrals. I should also mention actually that because this is weekly data, the big drops throughout the year are to do with bank holidays, when you have shorter weeks. observed versus expected urgent cancer, 2-week wait referrals, a big drop initially, like a frightening drop initially, to less than 50%, then recovered. And we're talking about kind of tens, I think almost 100 or 200,000. I don't have the numbers there in the paper, of consultations that were missing. I think it was 250,000 from memory, in this block, and things got back to where they were, which is great. But what you would hope to be seeing is a kind of recovery beyond that. So picking up cancer referrals that hadn't been made, but that should have been. And then routine referrals, I think anyone seeing a more recent version of this chart, it's still not back to the pre-pandemic levels of routine referral. And as I mentioned, yeah, 13% of ultimately diagnosed cancer start with a routine referral. So I think that's, you know, not necessarily brought into the discourse very much, but an important thing to think about. Now, using the NCRAS, so National Cancer Registry Analytics Service, Cancer Data Equity Pack, so they were releasing data on a monthly basis on what was happening in cancer diagnostic services. So the number of urgent cancer referrals basically dropped, and it dropped a different amount for different cancers, which is interesting. So the number of lung cancer referral dropped heavily, and the number of the first treatments dropped, but not by as much. So, but what's interesting to think about is the fact that COVID-19 was a lung-related disease. Were people not mentioning kind of lung-based symptoms, or were lung-based symptoms kind of overshadowing what was potentially a lung cancer diagnosis? Big drops in urological cancers, which includes prostates. I think there were basically lots of kind of men of retirement age who weren't going to the GP, and so weren't having their prostate cancer diagnosed. The number of first treatments for new breast cancer is the biggest overall fall, and that is very likely related to the halting, or I'm not sure if it was like a policy-based halting, but screening programs basically stopped. People stopped showing up to screening program, and breast cancer screening is a huge source of diagnosis there. So in the context of all that, so reduction in consultations, let's think about the levels of diagnosed illness and how it's different across socioeconomic groups. So using the Cambridge Multimorbidity Score, again, this kind of weighted count of conditions, we can compare the levels of illness across different groups. And what we're doing here is we're controlling for differences in age as well. So people living in the most deprived areas are much more likely to be younger, and people living in the least deprived areas are much more likely to be older. So we control for that. And we see that pretty much, so 60%, that there's a kind of 40% difference in the amount of diagnosed illness. And for people in deprived areas, the kind of dominant conditions for that, and this is in order going up and down here. So chronic pain is the biggest single contributor to diagnosed health inequality. Diabetes, COPD, alcohol problems, anxiety and depression, and then various cardiovascular diseases, so atrial fibrillation, CHD. Part of the reason I'm showing you this is that the prevalence of cancer is the only condition that flips this trend. And that's because prevalent cancer is different to incident cancer. And if you have people in wealthier areas more likely to be diagnosed with cancers with higher survival rates and more likely to be diagnosed at an early stage, then the prevalence of cancer will be higher. There will be more people living with cancer, simply because people with cancer in deprived areas are more likely to die quick. So chronic pain, COPD, alcohol problems, diabetes, anxiety and depression, these are conditions that are predominantly identified diagnosed, managed, treated in primary care. So we've got a lot of pressure on primary care services in deprived areas. This is reflected in differences in the consultation rates. So, and actually sorry, I forgot to mention, you've got this kind of ski jump aspect to this here. So you have a kind of linear trend where there's more illness, more diagnosed illness in each of the more deprived areas you go into. And then as you get into the most deprived areas in the country, it kind of accelerates. So you have much greater differences, much greater inequality between people who live in kind of similarly deprived areas in the most deprived areas of the country. But you have a massive difference. This is the weekly consultation rate in the number of consultations that are happening on a weekly basis in primary care in deprived areas. So the gap between the most deprived decile, which is 10, this red one, and 9, the next most deprived decile, is about the same as the gap between 9 and 1. So people in the most deprived areas, the very most deprived 10% of England, are using primary care much more, which again just builds pressure in primary care. That gap there is not explained by this gap here. The difference is not as big. So what we probably have is more people living in the most deprived areas, people with difficult lives, and people have written about this, more likely to be unemployed. Anecdotally, I was speaking to someone who works at Diabetes UK the other day, who used to be a GP in a deprived area, and quite often people would be talking to their GP about life issues. So people from kind of wealthier backgrounds who are kind of much more likely to have higher education degrees will often know a teacher or a lawyer, and so if they have advice that they need to get from someone, they can very often speak to a friend or family member. And for people living in the most deprived areas, they don't have that in their personal network and will go to and use primary care appointments to talk about things like that, just normal life stuff. And so that kind of the use of primary care is very different, and because of a lack of investment in community services, social services, you probably have GPs picking up a lot of that additional kind of demand for assistance or request for assistance. That highlights that big difference there. So the bottom line is people in the least deprived areas, then decile 9 and decile 10. Oh, actually, that's switched around in the ordering. Please forgive me. But the top one is the most deprived area. So when the lockdown started happening, GPs went out to their patient base and they said, come in for a checkup. We'll make sure that you've got all of your prescriptions lined up, and that basically there's a chance that you won't be getting access to primary care or services. We don't know how the advice is going to change. So they did a reach out and often remotely had a consultation with their patients. In the most deprived areas, you have the most people with pre-existing illness. So you had more people on the call sheet, or a higher percentage of people on the call sheet. So actually the reduction in consultation rates was lower in the more deprived areas than it was in the least deprived areas, which I thought was an interesting result. If you compare that though to urgent cancer referrals and first treatments, the fall was bigger in more deprived areas, which just, you would hope that these two things, if everything was working properly, if there wasn't inequality in access to care, especially primary care, you would expect for the urgent referrals and first treatments for cancer to be as protected as the consultation rate, but it wasn't. Why didn't that happen? So these results, along with kind of many others that I've mentioned before and are in this slide, highlight the relative fragility of primary care in deprived areas. The average number of issues raised in a GP appointment, based on analysis done in 2013, which was a long time ago, but actually this kind of research in primary care is relatively light, as I mentioned. It's 2.5. So you've got, and the recommended length is 10 minutes. So you've got on average 2.5 issues being discussed in 10 minutes. And in deprived areas, people are more likely to have more conditions. So you'll have people discussing 3 or 4 long-term illnesses, sometimes 5, 6, in a 10-minute consultation with a GP. The number of GPs per head of sick patient is lower in deprived areas. Appointments are shorter for the number of long-term illnesses, and that's because we have that fixed, we have that 10-minute consultation length and more conditions to go through. Staff turnover is higher, so you're less likely to have a relationship with a GP that's lasted a long time, where there's a lot of kind of interaction and familiarity there. There's greater morbidity and multimorbidity in deprived areas with greater complexity, and I've written about that. Cancer is more incident, but more commonly diagnosed at later stages in deprived areas. And so you've got loads of things all coming together. You've got lower health literacy, greater morbidity and complexity, and lower supply relative to need in deprived areas, what we call the inverse care law, if you're familiar with that. And this is contributing to greater inequality in cancer diagnosis. And cancer is just an example case. So, and the kind of great thing about cancer is that it tells you how well the system is working. Almost tells you how well the whole health of the population is working, because cancer is, we know that cancer incidence is more likely depending on your exposure to kind of health damaging risk factors. So it can tell you about how well your kind of population health is working. And because of the way the cancer diagnostic process works, kind of it's a real nose to tail condition. And it's also, so at diagnosis, it's kind of ranked. Obviously, early cancer diagnosis is the gold standard. So stage 1 is ideal and most treatable. But at cancer diagnosis, if you're diagnosed at stage 2, 3, 4, you know that that's because the system as it is isn't working, and that's more commonly the case in deprived areas. And I'll just talk a little bit about this kind of diagnostic overshadowing, blunt elbows, and it is speculation, and actually the diagnostic overshadowing term is more commonly used when discussing mental health issues. So someone with a mental health condition might have symptoms related to a physical condition that they have at the same time, but doctors can sometimes kind of misrelate the physical symptoms with the mental health condition, delaying treatment for that physical condition. There's a literature on it, and this kind of borrows from that. And I think one of the things that adds to that story was the reduction in the big reduction in lung cancer urgent referrals around the COVID-19 pandemic. So people were coming in with lung symptoms. The thought was not lung cancer, it was COVID-19. And similarly, if you've got patients living with COPD, people complaining of lung-related issues, and I'm sure there are other conditions where there's basically kind of this cross-pollination of symptoms that kind of masks red flags, and then is less likely to result in urgent cancer referral. And this kind of exemplifies that. So again, sorry, a complicated chart, but we're talking, so 10 is the most deprived decile, again, 1 is the least deprived. This is the bars are the rate of routine referrals, and the red is the rate of urgent cancer referrals. Now, what we're doing here is we're controlling for differences in age, and we're controlling for the average number of conditions in the population. And this isn't an exact science. and that's why it's under the speculation section. But if someone has more common, more multimorbidity, then they are very likely to have been more exposed to health risk factors, which then makes them probably more likely to have developed cancer as well. And so what we would hope, if the system was working equally, would be for the rate of routine referral and the rate of urgent cancer referral to be the same across all of these 10 groups, because then it would just be the differences in underlying illness. It would be the wider determinants of health that are causing that difference. But here, if you know, it's not a perfect control, but if it is working properly, then we're seeing that people in deprived areas, for their age and their level of illness, are less likely to have an urgent cancer referral. And just to revisit that kind of green shoots at the end of that narrative, I'm drawing to a close now. The green shoots are great. So the use of lung cancer diagnostic trucks, basically go into a community, especially deprived community, and encourage people to go through to take some relatively quick tests called lung NOTs, I guess. Has been really effective in diagnosing lung cancer at early stages, especially in deprived areas, which is a fantastic outcome, but one that has only worked because it sidesteps that primary care setting. So developing a cancer strategy that is also a primary care strategy and recognises kind of underinvestment in primary care, I think, would be a really good step forward in cancer policy. I won't go through this again, actually. I'll just kind of leave it up here if that's okay. Thanks very much for listening to my ramblings.
Thanks, Toby. That was really interesting, and I think in particular for me, the interesting data was learning about how the primary care in deprived areas is so much more intense, and that there's so much of a burden on the GPs because of the life issues that the patients come to talk about. So that was really interesting. I had a few questions. I haven't seen anything come up in the chat yet, so just a reminder, if anybody would like to post a question in the Q&A section. When you talk about the areas and the deprived areas, what are those areas? I'm interested to know if I live in one, and I was thinking about London, for example, where you probably got deprived areas literally next door to the more affluent areas. Like, how does that affect your data? Is that taken into account? And another question, you know, if I was somebody who was perhaps, you know, raised not necessarily in a deprived area, and I went to university and I had a good education, but then I go and live in a deprived area, does that make a difference? How does it all work, and how do you sort of delve into that data?
Yeah, so there's some really, so not to get sidetracked on this, but we can't do anything on economic mobility here because the data that we have, so CPID is a great data source, but they are very tight on making sure that there's no way that you can figure out where a patient lives or where a GP practice is. So what we have is the patient has a postcode, which is part of their kind of data, and the that postcode exists within what's called a lower super output area, which is a cluster that is typically around 1,000 people. Those 1,000 people, the ONS then assigns them into a kind of ranking based on deprivation, and the index of multiple deprivation, the score, is based on levels of income, education, health, and other outcomes within that area. So your first question was, how do you know which one you're in? It's basically you and around 1,000 people live near you are all in the same area. And so there's lots of weakness in that, especially in urban areas. You'll have lots of people with very different kind of education, health, and income levels, all clustered in the same area. There is the opportunity to do analysis by urban-rural split, but I haven't been able to get hold of that. I haven't been able to get hold of that yet. And what's really interesting, so as an economist at Harvard called Raj Chetty, who's done lots of analysis on this, and obviously for our patients, that IMD score is static, but you can see if you do get data on mobility, that people who move from one area, from kind of a deprived area to a wealthy area at younger ages especially, that can send them on very different trajectories. And I think that kind of work would be really well lent to this kind of thing, which is about the importance of kind of early intervention for income as well as health outcome.
Thanks, Toby. Another question sort of from me, but also somebody posted something quite similar. I was just thinking as you were talking, this must just be really frustrating. I know you're not a clinician and you're an economist, but to have this data and know that there is such a problem, that's probably costing the NHS a lot of money. How does this get taken forward? How is this useful information taken forward? Whose responsibility is it? Is it the patients? Is it the government? Is it the trusts? And the comment from one of the audience members was, if literacy is a problem or an issue, could videos and ads help in cancer awareness in deprived areas? Now, how do we educate people? Would that make a difference?
It's very difficult to know whether it would make a difference. Again, I'm speaking kind of anecdotally here, but one of the problems is that the system as it stands relies on engagement, and actually that's what the lung health checks have done, is to take that kind of patient emphasis away, or at least reduce it a bit. I think obviously, again, just speaking to GPs who work in deprived areas, they know that there's probably a huge amount of undiagnosed cancer in their patient registry, but they're worked, they're cover to cover all day, flat out, and it's the current system has it. The patient has to come in to engage, to make that appointment, to raise those issues, and actually often patients are very scared of cancer as well. So someone who has smoked for a long period of time is starting to get lung symptoms or major concerns about lung-related health, knows that if they do believe they have cancer, that kind of facing up to that is a really scary prospect, and people just kind of don't want to hear it and don't engage with it for those reasons. So it's basically really, really difficult, and I don't think there's any one thing. You can't blame one person, or you can't say it's the patient's job or the GP's job, or because a lot of these ideas that and suggestion on video ads, someone's definitely thought of that already. It's about a kind of blanket approach to improve these processes, but also building in a little bit more resilience in the setting that we already have, because at the moment there isn't a great deal with GP wait lists as long as they've ever been, and GP satisfaction surveys really low, and workforce surveys, people complaining about burnout more and more.
Toby, one question that was submitted was, I'd be interested in NHS England statistics on cancer referral to treatment timelines, especially breast and cervical cancer, for Black and ethnic minorities versus Caucasian patients in 2021 and 2022. The Guardian newspaper did an article on health disparities, and it would be interesting to see statistics from NHS England.
Yes, those are accessible, and I did a I just show you, I just share my screen. We did some analysis on ethnic inequalities, especially in primary care, because it's in the data. It's not perfectly recorded, obviously, because the coverage isn't great, and it's in a GP record, which obviously doesn't necessarily accurately reflect people's ethnicity. And in the cancer registry data, their ethnicity is recorded as well. I'll just share my screen quickly. So there's cancerdata.nhs.uk. If you go through, there's the COVID-19 dashboards, which basically allow you to ask many questions about cancer diagnosis in the last couple of years, and you can do things by stage, by treatment, diagnostic intervals, which is really interesting. And then there's also down here, there is what's called the NCRAS, the Cancer Alliance Data Evaluation and Analysis Service, CADIAS, who did cancer equity things. So they look at urgent, suspected 2-week wait referrals, first definitive treatments, and they do so by socioeconomic inequality. So that's where a lot of my analysis came from, and also by ethnicity. So you can look at these things, and you can look at them compared to how they were before the pandemic. But I think one of the major questions is, before the pandemic, was the rate of urgent cancer referral for those things in minoritized ethnic groups correct? Like, was it the right, is it the right amount? And actually that raises bigger questions about what the right amount is for any person. But if you have inequalities in, if you have general inequality, you have health inequality, then you have inequalities in the likelihood of people developing cancer. And so understanding how well the system is working for different groups of people is a real challenge, and getting new access to the data is really important to try and dig into that. So this kind of high level stuff is useful, but it has its kind of limitations as well.
Thanks, Toby. Final question that was pre-submitted. Referring to the Lung Cancer and Health Inequalities document from UK LCC, November 2022, how can we develop research themes across the sector for lung cancer patients that are meaningful?
Cross sector. So the a clarification would be great on cross sector. So part of the thing about this, and so this analysis was conducted using primary care data and then NCRAS cancer registry data. We now have access to linked data, but that data then doesn't link to smoking habits. So obviously it would make my job a lot easier if all the data was linked, but it would also make policy decisions a lot better, and identifying people at high risk of lung cancer would be much easier if policymakers and analysts had access to linked data, especially on health and the wider determinants of health. I think that's something that, you know, is not a million miles away, and could be done more quickly. And it, you know, people have concerns about the risks of people getting access to their data. But if it's protected and it's used in a sensible way, I think it can make basically lots of people's lives a lot better.
Thanks, Toby. I don't have any more questions from the audience, unless any pop up, but I will just wrap up and just sort of reiterate my thoughts that it's just a stark reminder of how sort of fragile and valuable our primary care services are. So it's quite sort of frightening to hear, you know, what you say, but it's really interesting, and we'll look out for more publications from you. Thank you. So thanks everyone for joining us, and Toby especially. If you've got any further questions, I'm sure Toby would be happy to follow up after the webinar. Please visit our website, owenmitchell.com, for any legal updates and information about future webinars. There is one more webinar in this health inequality series that will take place on the 19th of July. This is looking at health inequalities in diabetes specifically. The link should be posted on your screen now. And finally, if you could just let us have some feedback, that would be really helpful. Thank you for future reference. And just thank you again for joining us.
Thanks everyone.